Thanks, Paul. That was great. Let me ask you and maybe Hamel and Conrad and comment on this a little bit. Based on what we see, whether it's data, results, and competency, perhaps, one of the things that we all feel or think is that tricuspid percutaneous replacement is likely to be approved before percutaneous mitral valve replacement.
Yep.
Is that, I mean, despite a big, obviously, lag in starting the two different strategies, right? Tell us a little bit about that and your opinion on it.
Yeah, I think, well, I mean, the data from Triluminate came out first. We're going to have follow-up. It'll probably go to the FDA first, and it'll probably be approved first. I think it's going to be fairly quickly followed by, we don't have the EVOQUE data, so I'm, assuming we see similar results with EVOQUE. Certainly the safety profile appears to be favorable. If that happens, I think we're going to then try to figure out which patients are best treated with edge-to-edge repair and which patients are best treated with TMVR. The reduction in TR between the two is dramatically different. It's much better with a valve replacement than it is with repair, and they both seem to be well tolerated. So I think we need more data to answer that question. But I think these patients are desperately sick. Anybody who takes care of patients with recurrent heart failure with severe TR, they're looking for something, and feeling better is a very solid endpoint. So I think we'll be busy with both.
Yeah, and this may be a little bit controversial, but imagine if tricuspid valve replacement was perhaps the data was perhaps available at the same time as repair, and perhaps the data was more convincing than just pure quality of life. It's hard for me to imagine that the FDA would approve. I mean, tricuspid regurgitation, we all know they're sick patients. We just didn't find out about them till now. So they've existed for a long time. So it's just, food for thought, something to think about whether or not FDA would readily approve those and whether these would be paid for, quite frankly, down the line.
Yeah.
Couple questions. I know the big theme early on was talking about earlier intervention and perhaps low flow, low gradient. We talked about earlier intervention for valvular disease. Josh and Bill, you both talked about that. Part of this, I look at it a little bit differently, and we have these discussions in the office all the time. You said, "Oh, I just sent a great young person for TAVI. Keep an eye out." That usually means that patient's probably not straightforward. That's why you're giving us a heads up. But more importantly, here's the conversation that Dustin and I often have with patients in the clinic. If we put a valve in somebody who has moderate AS, or is perhaps asymptomatic, not critical, not severe, moderate AS, or low flow, low gradient, severe AS, perhaps. Two components of that. You put a biprosthetic valve in that person, they're not getting a mechanical valve, right? You're resetting the clock, right? So they're barely feeling crappy now, and all of a sudden you're going to reset the clock. They're going to be back sooner now to get their valve and valve, TAV and TAP down the line, right?
Yeah, I mean, clearly, I think you're worried about these valves failing in 7 to 15 years, and if they're only moderate AS, then obviously we have to worry about late failure and then needing valve and valve. That's a theoretical and I think appropriate viewpoint, and the bigger theme that I see here with all these talks is sort of the concept of how do we figure out a state where we're going to create a good environment as an institution and internationally for asking this question in a fair way. Meaning, you may be 100% right that intervening on patients in the short term may be helpful, but in the long term may hurt the patient. But I think when we've done these intervention trials for TAVR, we saw a very early stroke signal, and we were worried TAVR was going to be worse for patients. And in the long term, we've seen TAVR has been a huge success story. So I think the broader concept of we need to do the RCT, we need to enroll patients to find out, I think is more important because I don't know the answer. But it may be that the clearly intervening is the right thing to do. And then we need to put the pressures on the companies to get a better valve that lasts, has better tissue, to know that intervening early is right, we just need to get a better valve. But your point's well taken.
Yeah, I mean, there's no data to suggest that somebody has moderate AS, they're going to decalcify their prosthetic valve also slower. I mean, likely not the same, right? Bill, thoughts?
I'll just add, you have to have the right diagnostics. Make sure it's only moderate, or maybe it's really severe. And I think the exercise testing can help. So,
That's a great point. And I think low flow, low grade AS is probably one of the most abused diagnoses.
yeah. And, looking more thoroughly at the ventricles, is there a lot of fibrosis developing? Is the strain abnormal?
No, that's a great point.
And the calcium burden can be helpful as well in the CT, looking at the calcium burden that comes with that.
No, absolutely. I think those are all great points. Brian or Jackie, when you guys focus on transcatheter pulmonic valve replacements, tell us a little bit about anticoagulation, gradient issues, low flow systems. Is that something that you talk to them in children, adolescents? Very challenging. ACHD patients, probably a different issue.
Yeah, this is a great question, Eves. I appreciate it. The challenge for us right now is the volume is not comparable to your volume. So we see a small signal of some early leaflet thrombosis in a small percentage of patients, but most patients are being managed with aspirin alone, varying from pediatric population all the way through adult population. So 60-year-old patient who gets a transcatheter pulmonary valve replacement is going home on aspirin alone, the same with a 15-year-old patient. We follow early and often for the development of gradient, and if that happens, they end up on usually a DOAC as a strategy for 3 to 6 months.
Yeah, that's a good point. Great.
Very few times that on ice, immediately after the procedure, we see little fibrous strands, and we anticoagulate those patients.
Yeah, that's a good point. I think having a right side of circulation is different. And this is the other point I would not that I'm beating on Josh right now, but
please.
Brian can say, oh, you know what, I can do 5 more of these if they continue to fail. We can't say the same thing for TAVI, right? So a different concept, different anatomy. So anyway, that's why I perseverate. Agnes, I think I've been on multiple email chains with you, Katie, and others that talk about, patients who are high risk from the cardio OB team. How often do you do invasive measurements, right heart cancer? Are they ever helpful from a management perspective, or is it virtually all, well, let's get a CMR, let's get a TTE, and go from there?
Yeah, I think we rarely, but do right heart caths. I think we collaborate a lot with our anesthesia team, and I think if during delivery there's a question of, will their hemodynamics, particularly in active pushing, compromise their cardiac output, I think oftentimes the right heart cath will be helpful, and we will do that if that will be helpful in answering the question, but not often. Great,
that's good to know. Samir, you alluded briefly to Champion and Catalyst AF. The PREVAIL data, PROTECT AF data, all that you talked about, the difference comes up when it comes to hemorrhagic stroke, not ischemic stroke. And that probably all goes down to mortality. How do you think this will be looked at from that perspective? I know obviously the endpoints are different. I mean, this was controversial when approved, likely going to be controversial, but give us your view on this.
Yeah, so the PREVAIL and PROTECT AF went up to 5 years, and obviously some of those patients that have atrial fibrillation have a longer longevity, so we need longer data. As you saw, the endpoints of the newer studies, the Catalyst and the Champion, are a little bit different. Definitely non-inferiority in terms of the efficacy, but then superiority in terms of the non-procedural bleeding, which is important because you want to factor out, obviously, what happens during the procedure. I think it's a lesser concern in my mind, the fact that we're factoring out the procedural bleeding, because we know from the data that we've had accumulated over registries and trials that the procedure is fairly safe. I think that those trials have a very good likelihood of turning out positive. I think that it doesn't, in my mind, clear up completely the fact that there may be an advantage from the ischemic stroke with anticoagulation, correct? We know that some clots form on the outside of the device. We know that not all the clots in the context of atrial fibrillation form in the left atrial appendage. They could form elsewhere. So there may be a little bit of an added protection from being on anticoagulation. But at the same time, the offset is with the bleeding. So if these trials turn out to be positive, my read on it is that it will not necessarily open up that everybody's going to get the left atrial appendage closure, but it will free us in terms of making that choice when we have other considerations.
That's a good point. Kathir, one of the things that we hear, thankfully not locally, but we hear when we travel is, a variety of, particularly interventionalists talking about, well, these patients don't really, first of all, please don't do anyone with general anesthesia without ET2 for our patients. Let's just start there. Second of all, we hear this concept of, well, I don't really need cardiac anesthesia. I don't really need anesthesia. And this happens a lot in Europe when we see that, or Asia. Tell us a little bit about what your viewpoint of this. Obviously, you're biased, but how safe is that, and how do you feel about it?
Yeah, so I think anybody who has the total understanding of cardiac physiology, what happens in the operating room with interaction of different things, will be able to handle the cases. For example, if there is an ECMO patient coming for an explorative laparotomy, I'm not coming in the middle of the night to give anesthesia. So it is a very sensitive matter between cardiac anesthesia and non-cardiac anesthesia, but I believe that with proper teaching, typical example is a VAD patient coming for non-cardiac surgery. If I have to do all VAD patients anesthesia, so I have to be there 24/7, so that's not going to happen. So what we do is we conduct CME courses for non-cardiac anesthesiologists to educate them what is right ventricle, what is pulmonary hypertension, what is interaction. With the close interaction, close teaching, close coordination, that we will be able to get some non-cardiac anesthesiologists to do cardiac cases coming for such procedures. So it's not totally nil, but the cardiac anesthesia has to be on phone, has to be consulted before anesthetizing such patients. So it is more of a, cardiac anesthesia is only 10 people in the system. So, but there are more patients with cardiac diseases. So we have to involve other people.
That's a great point. Katie, you want to close us up? Any final comments, apart from telling everyone that the heart team is very much alive in Pittsburgh and Harrisburg and everywhere else in the UPMC system?
No, I just want to thank all the organizers for organizing this valve symposium. I think it will be tremendously helpful for not only physicians, but as an advanced practice provider. I know that I learned a lot today, so thank you.
Great. Thank you, Kate. And I learned a lot today, too. Multiple, obviously, fantastic talks. Thank you again, really, to Hemel and Conrad for helping us really put this together, and the expert faculty who are all here took time off on Saturday to spend time with us and with the virtual audience. James Ferris and the massive media team, Drew Burkott and Shelley Miller for traveling from Harrisburg. Appreciate all your help with putting the program together. And of course, Angie Kanunen, without whom really nothing happens at UPMC HVI. So thank you, everyone, and thank you all. Appreciate it.